Hello, my name is Marian Apellanis, and my presentation is going to be on vitamin D supplementation for adolescents and young adults that have lupus erythematosus. So, systemic lupus erythematosus, or SLE, is an autoimmune disorder and it attacks multiple tissues and organs. Juvenile onset SLE is associated with significant mortality. It has very uncomfortable symptoms that can affect quality of life tremendously. It has increased inflammation, systemic inflammation, gastrointestinal disorders, chronic pain, dermatological symptoms as well, mainly around the facial area. Vitamin D, however, is very often deficient in these patients, and it's known for its immunomodulatory properties and is linked to decreased inflammation as well as regulatory immune responses. However, it hasn't been well studied with patients that have SLE, especially juvenile onset. So that is what this study is about. So my clinical question is, in a 16-year-old adolescent Asian female with lupus, would weekly supplementation of vitamin D decrease fatigue and improve autoimmune response and physical activity performance? So for my PICO question, for the P, I used a 16-year-old Asian female with lupus. The intervention would be vitamin D supplementation. The comparison group, I had a little bit of issue trying to figure out what to write down here, but I decided just a normal diet therapy without that vitamin D supplementation. And then the outcomes are fatigue, autoimmune response, so disease symptomatology basically, and physical performance. The mesh terms that I ended up using were the ones that you see over here in the bold. However, all of the other ones were the ones that I kind of had in mind while I was looking for an article. This is the research paper that I ended up using, and it's called Vitamin D Supplementation in Adolescents and Young Adults with Juvenile Systemic Lupus Erythematosus for Improvement in Disease Activity and Fatigue Scores, and it is a randomized, double-blind, placebo-controlled trial. So for the PICO question, or the PICO portion of the study, the population were young adults. They were 25 years or less, and they had juvenile onset systemic lupus erythematosus, or SLE. The intervention used was a weekly supplementation with 50,000 international units of cholecalciferol, or vitamin D, and this was done for 6 months. The comparison group received a placebo capsule also for 6 months, and the outcomes measured, there were primary and secondary outcomes. So the primary outcomes were improvements in disease activity scores. They used the Systemic Lupus Erythematosus Disease Activity Index, or SLEDI, and the European Consensus Lupus Activity Measurement, or ACLAM, or ECLAM. There were secondary outcomes measured that were important. These were the KID Fatigue Severity Scale, or the KFSS, and the normalization of vitamin D levels, which was important, which I'll talk about in a little bit more forward, and the safety assessments such as serum calcium levels and any adverse events. The setting of this study was in Brazil, in Sao Paulo. The inclusion criteria was the patients had to be 25 years of age or younger. They had to have a diagnosis of juvenile onset SLE. This was based on the American College of Rheumatology criteria. So this disease onset had to be before they were 16 years of age. And the participants did have a baseline vitamin D deficiency of less than 30 nanograms per milliliter, and this was at baseline. The exclusion criteria was hypercalcemia or hyperparathyroidism, chronic kidney disease, stage 3 or higher, any patient that was already utilizing a high dose vitamin D supplementation prior to the study, and this was considered 1,000 IUs or international units daily, and any other condition or medication that could interfere with vitamin D metabolism. So this was a double-blind randomized controlled trial. So the participants and the researchers were all blinded. They were randomly assigned with a computer-generated program to either receive the 50,000 units of vitamin D for 6 months or to receive the placebo pill also for the 6 months. The randomization that was used, it ensured that the patients in each group were comparable when it came to demographics, clinical studies and immunological factors, age, sex, disease, duration, and the SLE-DAI or SLE-DAI studies and the ECLAM studies, as well as the KFSS. Everything was very similar at baseline, and this ensured that any changes that happened towards the end of the study had to do with the vitamin D supplementation and not because of baseline heterogeneity. The study did have the intention to treat, so we had the same amount, or the amount of patients that were started in the study was the same amount that was looked at the end, so it didn't matter if there were dropouts. Everybody was taken into account for the results. So as far as the results of the study, there was a clinical improvement in the SLE-DAI and the ECLAM scores after the 6 months. So this means that there was an improvement in the disease activity index and in the activity measurement for the patients, like we had mentioned before. So after 6 months, those with the vitamin D, they did have significantly important results with a p-value of 0.11 and 0.06 respectively. Of note, something else that was important was that the vitamin D group, they also had higher, and this is 25-hydroxy D, or that's how we measure vitamin D levels. So they had greater levels than the placebo group, and this was with the p-value of less than 0.001, so very significant. The outcomes were both clinical and physiological. So the clinical outcomes were the scores for the SLE-DAI and the ECLAM, and the fatigue levels, which were the KFSS. The physiological outcomes were vitamin D levels, the antibody levels, and the calcium levels. These all are important markers of clinical outcomes in SLE. And then they also measured the adverse effects or the adverse events, but there really weren't any other than some minor gastroenterological symptoms, but nothing was very significant. So they did measure all of that. Okay, so in the statistical part of the study, it was a little bit more tricky to analyze, and I'll talk about it. This was because whenever we were looking at the results, and I'll show it in a further slide, they weren't looking at whether patients developed a particular outcome or not. It was more, so first of all, this one was a little bit in the reverse towards the outcome that we were measuring is actually the positive outcome that we wanted. So that is an improved level of vitamin D. And so they were looking at that, and they were also not looking at whether a particular symptom or outcome happened or not. It was more looked at percentage. So what percentage of the participants ended up having that increased vitamin D level, right? So this made it a little difficult to come up with these numbers, but I did some research that helped me with the interpretation of it. So for the relative risk, because this number, when you did the math, it ended up being undefined, that means that there is a complete benefit of the intervention over the placebo. And that was the same thing for the relative risk reduction. It comes out as undefined because one of the numbers is 0. because this happened because 70% of the patients that received the vitamin D supplementation gained a normal level of vitamin D level at the end or after 6 months, versus no patients in the placebo group were able to gain that level of, or to normalize those vitamin D levels. So that's what we are looking at here, and that is why when we look at the relative risk and the relative risk reduction, the number comes out as undefined. Now, when you're looking at the number needed to treat, this is also different, because this means, or the way that you read it is, for every 2 patients that you treat, then there would be 1 patient that wouldn't benefit, if that makes sense, or there would be 1 extra patient that wouldn't benefit. So I can talk about it a little bit more in the next slide. Okay, so the way we look at it here, this is all in percentages, right? So we've got our patients that got the vitamin D right here, and then the patients that got the placebo. So here, the amount of patients they were able to have more than 30 nanograms per milliliter was 70%. So 30% of the patients in this group had nanograms per deciliter of less than 30. And then over here, it's 100% of the patients that received the placebo weren't able to gain those numbers, if that makes sense. So that's why all of these over here have a p-value of less than 0.001. And that is why the numbers in the previous slide come up to 70% of the patients that received the intervention actually ended up regaining this over 30% nanograms per milliliter. So it was a little bit tricky to understand these numbers, but I hopefully that makes sense. And then over here, this is just the other p-values that I was talking about. That was 0.011 and 0.006. As far as a conclusion, I do believe that the intervention would be worth the potential risks. So this study did show that vitamin D supplementation was well tolerated. There were no serious adverse events. Vitamin D, however, is a fat-soluble vitamin, so this means that there is an upper limit. So it does exist. Because of this, interventions that are to go on for longer periods of time with certain disease states or with patients that don't have a vitamin D deficiency at baseline just would need to be well monitored in terms of toxicity. A difference in the patients with this study and my patient is that these patients did have a baseline vitamin D deficiency, whereas my patient did not. And just for some clinical outcomes and what affected my decision making is the study did show that vitamin D supplementation in young adults and adolescents with lupus and vitamin D deficiency at baseline did have a reduction in disease activity scores and better disease control and improved immunological markers. The intervention also showed to be especially important in improving fatigue and normalizing vitamin D levels. So this is very common for SLE patients. And so vitamin D can be used as an adjunct treatment to improve quality of life and outcomes, and it's safe and low cost. And thank you very much. This was my study. I think overall I would give it a B. It does have some limitations. In other areas, it doesn't completely correlate to my patient, but I did like that it was done in adolescent patients, and it gave me the idea to think about vitamin D supplementation, which I think would also be good for an athletic patient, which is the case of my patient. So thank you very much.